Hello and welcome everyone. Today we are covering part 2 of melanoma video. We have already covered the cause, diagnosis, treatment for melanoma in previous video. In this video we are learning mainly gross and microscopic features of different type of melanoma. The characteristic sign of early melanoma are recognized with the following well-known A, B, C, D, E mnemonic. A stands for asymmetry, B stands for border. The border is irregular, ragged, notched or blurred edges. C stands for color. Color would be non-uniform or variegated. D stands for diameter. The diameter of lesion is more than 6 mm. E stands for evolving. The lesion changes in size, shape or color with the time. Most important aspect is differentiating melanoma from benign nevi. Melanocytic nevi are defined as benign, well-circumscribed melanocyte proliferation in the skin. These melanocytes are aggregated in nests. Melanocytic proliferations are mostly located in the basal epidermis, junctional zone called as junctional nevi, or dermis region called dermal nevi, or they may be also seen in deeper layers like subcutis, which is called deep penetrating nevi. There are many types of nevi such as melanocytic nevi. Dermal melanosis includes otitis nevus, etos nevus and congenital dermal melanosis, also called Mongolian spot. Blue nevus, lentigo simplex, junctional nevus, compound nevus, dermal nevus. Michener nevus, Zitelli nevus, Unna nevus, Clark nevus, nevus spillus. Congenital melanocytic nevi, splits nevus, Wiesner's nevus, etc. Melanocytic nevi are benign clonal proliferation of melanocyte possessing generally heterogeneous clinical and molecular properties. This picture shows histological images of melanocytic nevi. Two types of nevi demonstrated here. First is intraepithelial junctional nevi. They are confined in epidermis and it press against the basal membrane forming a characteristic rounded pockets of densely packed cells. And second figure showing dermal nevi. They are confined in dermis. Cells are loosely packed and they do not touch the basement membrane. The distinction between nevus and melanoma are tricky, but there are some identification features such as nevus cells mature with the depth, while melanoma cells remains approximately the same size in the top and the bottom of lesion. HMB45 labels only cells in the epidermis and upper dermis of nevus in this picture, while it highlights the scattered melanoma cells throughout the lesion in the melanoma. With Ki67, nevus cells have a minimal proliferation rate. In contrast, the melanoma cells show high proliferation rate. The characteristics of melanoma. First is epidermal finding or in situ melanoma. It has a ill-defined border or pagetoid melanocytes. Single scattered melanocytes especially in the upper layer of epidermis. Epidermal consumption or ulceration can be seen. Irregular distribution of junctional melanocytes can be seen. It is characterized by confluent growth or skip areas or nests of different size or shapes, irregular distribution of nests, discohesive arrangement of melanocytes. Let's focus on the dermal component. There are two phases of melanoma in dermal component. First is radial growth phase, invasion of single cells or nests in papillary dermis, and the vertical growth phase. Early vertical growth phase shows dominant nest within papillary dermis. Complex and asymmetrical growth pattern. It suggests irregular nests or fascicles. absence of maturation, lack of decreasing size of melanocytes or nests from top of the base of the lesion, increased dermal mitotic activity and tumor necrosis. These all are microscopical features of melanoma. The 2018 World Health Organization classification of melanoma categorized the melanomas into following categories. Melanoma typically associated with cumulative solar damage, that is pathway 1. It is superficial spreading melanoma or low CSD melanoma. Pathway 2, which is lentigo maligna melanoma or high CSD melanoma. Pathway 3, desmoplastic melanoma. Melanoma not consistently associated with cumulative solar damage, that is pathway 4, splits melanomas. 5, acral melanoma. 6, mucosal melanoma. 7, melanoma arising in congenital nevi. 8, melanoma arising in blue nevi. And 9 is uveal melanoma. 4 major variants of primary cutaneous melanomas are superficial spreading melanoma, nodular melanoma, lentigo maligna melanoma, acral lentiginous melanoma. Let's learn one by one. First is superficial spreading melanoma. It is the most common type of melanoma. It exhibits the hallmark of melanoma features like asymmetry, irregular border, color and increased diameter, etc. It has a prolonged radial growth phase characterized by intraepidermal expansion. It has no dermal invasion. Epidermal findings commonly seen in superficial spreading melanomas include unrestricted melanocytes and increased number of singular melanocytes rather than melanocytes nests, abnormally distributed and non-conjoint melanocytes, and melanocytes identify above the basal layer, which is called the pagetoid spread. Second is nodular melanoma. They do not follow the ABCD. They are symmetrical. They have regular borders and are generally of one color, but they are elevated, firm to touch and growing. So here EFG is applied. Nodular melanoma grows fast downward and can become invasive in months. Nodular melanoma is located in chronically sun-exposed areas, head and neck. Histologically, a vertical growth phase only and absent of radial growth phase. Nodular melanomas have similar finding to superficial spreading melanomas, except they are sharply circumscribed. Rapid growth and usually present at an advanced breast lobe depth. 15 to 20% of primary melanomas and responsible for 40% of melanoma deaths. These melanomas have poor prognosis because they have higher rate of growth and metastasis. Third is lentigo maligna melanoma. It is seen in elderly patients with chronically sun-damaged skin on the face. Characteristic histological findings of this lesion include epidermal atrophy secondary to severe sun damage and melanocyte running together along the dermal and epidermal junction with epidermal extension. Junctional proliferation of predominantly solitary units of melanocyte. Small hyperchromatic cells with a dense nuclear chromatin are typical. Cell nucleoli are usually not seen. Multinucleated melanoma cells are common. Pagetoid spread is usually only seen with advanced disease. Fourth is acral lentiginous melanoma. This type of melanoma is rare, usually found in nail beds and therefore has a delayed diagnosis. The main sign of acral lentiginous melanoma is a black or brown discoloration that appears on the sole of foot or palm of hand. They may resemble a bruise or stain, but over time it grows in size. Histological findings associated with this lesion include melanocytes in the nests and as isolated cells along the dermal junction. Widespread pagetoid spread upward is typical. Pagidot spread can also be observed in the benign form of this tumor but usually has a minimal extension. Melanocytes are often hyperchromatic and nucleoli are challenging to visualize. Next is desmoplastic melanoma. It is often amelanotic and has a predominantly dermal component. It represents as amelanotic nodules or plaque or scar-like lesions. It is characterized by the association of invasive melanoma with abundant collagenous matrix, giving a tumor a look of pink scar-like appearance on a routine H&E staining. Desmoplastic melanoma is the most common on the sun-exposed area of head and neck. It usually lacks the ABCD melanoma warning signs. It has been further classified into two histological subtypes, pure type and mixed type, based on the degree of desmoplasia present in the tumor. Pure desmoplastic melanoma is typically paucicellular with individual tumor cells dispersed in or separated from each other by the fibrous tissue. In contrast, the mixed type has a higher cell density than the pure desmoplastic melanoma, which may be throughout the entire tumor or manifest as a nodules of solid spindle or epithelioid melanocyte in the background of paucicellular desmoplastic melanoma. Nerve involvement by this tumor is common. In the IHC, typically scar contain only scattered isolated S100 positive cells, where desmoplastic melanoma is typically strongly and diffusely positive for S100 protein. Next is Spitz melanoma. Spitz nevi are composed of epithelioid to spindle melanocyte with abundant homogeneous cytoplasm and large vesicular nuclei, and often display epidermal hyperplasia, cleft around and between melanocytes, communobodies, and maturation with descent. It can be amelanotic or pigmented. It is mostly a morphology based diagnosis. Genetic hallmark of melanomas of skin with low cumulative sun induced damage such as BRAF and NRAS mutations are seen. The melanocytes are epithelioid and pleomorphic and distributed as a single cells and elongated nests in between the dense sclerotic collagen bundles. Next is mucosal melanoma. Mucosal melanoma is a rare and aggressive subtype accounting for 0.8 to 3.7% of all melanomas. Mucosal melanoma is occurring in the gastrointestinal, respiratory and urogenital mucosa. Clinical manifestations such as bleeding or pain can help to detect this tumor. Mutational landscape of this tumor include mutation of BRAF and NRAS and also mutations in c-KIT and CD117 gene. The nasal cavity and sinuses are common sites. Most patients suffer from nasal obstruction, visible mass and epistaxis that in some cases it causes pain, morphological changes of face, ptosis and diplopia. Mucosal melanoma frequently affects oral cavity and anal canal. It develops as a de novo asymptomatic melanocytic lesion with onset of bleeding or pain. Most common type of GI melanoma is anorectal mucosal melanoma. It is third most common site after cutaneous and ocular melanoma due to malignant transformation of anal and rectal melanocytes. It causes rectal bleeding, pain or discomfort. Urogenital tract melanoma is more common in females. They develop in vulva, vagina, cervix, urethra and urinary bladder. The most common site of urogenital tract melanoma is vulvar, followed by vaginal. The second most frequent vulval cancer is vulvar melanoma. Symptoms include bleeding, lumps or masses in vulvar area, itching, pain or irritation, discomfort and discharge. Main genetic alterations are KIT, BRAF, NRAS mutations and alterations. So this is in short about the types of melanoma. Though the melanoma is a very huge topic, I tried my best to cover almost all types. And these are the references for this video. Thank you. Bye. See you in the next video.